Hi, I'm John, your host, and welcome to Heart of Care, a podcast by AMCU. Here, we delve into the real voices of healthcare, sharing stories of resilience, humanity, and the unwavering heart that drives it all. Join us as we empathize, learn, support, and even find moments to laugh together. Thanks for being here.
Heart of Care, Season 2, Episode 2. Referrals that go nowhere. The crisis at the gates of public health care. Host, John. Guest, Dr. Evan Hope. Welcome back to Heart of Care, the podcast dedicated to dissecting the realities, often stark and unsettling, behind the Australian healthcare system. I'm your host, John, and today we delve into a deeply troubling phenomenon, one that undermines the very foundation of equitable access to medical care in this country. It's a silent crisis unfolding within our public hospitals, and it's leaving vulnerable individuals stranded and suffering. Consider this scenario. You've been experiencing persistent health issues. After weeks, perhaps months, of deliberation and discomfort, you finally consult your general practitioner. You place your trust in their expertise, sharing your concerns, undergoing examinations, and perhaps even preliminary investigations. Your GP, recognizing the need for specialist intervention, diligently crafts a referral, a formal request for care within the public hospital system. A sense of relief washes over you. You believe you're finally on the path to recovery. But then, the unthinkable happens. Instead of an appointment notification, you receive a cold, impersonal letter. It informs you, often without detailed explanation, that your referral has been rejected. No alternative pathways are offered, no clear reasons are provided, and most devastatingly, the care you desperately need remains out of reach. This isn't an isolated incident, a mere administrative hiccup. Evidence suggests a disturbing trend, a systemic issue quietly gaining momentum. Across metropolitan public hospitals, particularly within the burgeoning southeastern corridor of Melbourne, well-intentioned GP referrals are being dismissed on an alarming scale. And behind each of these disheartening rejection letters lies a human being, grappling with pain, navigating a maze of confusion, and ultimately, feeling abandoned by the very system designed to protect them. Returning to shed light on this critical issue is Dr. Evan Hope, a dedicated general practitioner who has witnessed firsthand the devastating impact of these referral rejections. He's here not only to illuminate the intricacies of what's going wrong, but more importantly, to underscore why this silent crisis should concern every single Australian.
John, thank you once again for providing a platform to discuss these crucial, yet often overlooked aspects of our healthcare system. I must confess, the issue of rejected referrals is among the most profoundly frustrating challenges I encounter in my daily practice. We're not talking about minor oversights in paperwork or the occasional administrative slip-up. We're confronting a system that has, either by deliberate design or negligent oversight, created a situation where patients are systematically falling through the cracks. This is happening under the guise of a functioning healthcare system, creating a deceptive facade of accessibility. As a physician, witnessing the emotional and physical toll this takes on patients is genuinely heartbreaking. As a citizen of a country that prides itself on its egalitarian values, it should be a source of collective outrage. And for anyone who believes in the fundamental principles of equity and universal access to healthcare, I believe it's imperative that we all begin to pay close and critical attention to this unfolding crisis.
Dr. Hope, let's establish a baseline understanding. In an ideal and properly functioning healthcare system, what should the referral process entail?
In its intended form, the process is remarkably straightforward, or at least it ought to be. A general practitioner conducts a thorough assessment of a patient's condition, identifies a specific medical need that falls outside the scope of primary care, and subsequently generates a referral to the relevant specialist department within a public hospital. That department then undertakes a process of triage, evaluating the urgency and complexity of each case. If the condition isn't deemed immediately life-threatening, the patient is appropriately placed on a waiting list for an outpatient appointment or procedure. While the ensuing wait times can be understandably frustrating for patients, this system, in principle, ensures a fair and prioritized allocation of resources based on clinical need. However, the concerning reality we're witnessing is a significant deviation from this ideal. Increasingly, referrals are not even being subjected to the triage process. Instead, they are being rejected outright, often accompanied by vague or entirely absent justifications. And when a referral is rejected in this manner, it effectively creates a void. There is no clear pathway forward for the patient, no transparency regarding the decision-making process, and ultimately, no access to the necessary specialist care. It's a clinical dead end.
So, Dr. Hope, what are the underlying factors contributing to this systemic breakdown in the referral process?
It's a confluence of deeply concerning issues, John. At its core, it stems from a toxic interplay of chronic underfunding of the public hospital system, an unsustainable level of overcapacity within these facilities, and, let's be frank, a prevailing political imperative to present the healthcare system as efficiently functioning. Hospitals are often judged, and indeed funded, based on metrics such as the length of their waiting lists and the speed at which they manage emergency cases. However, these metrics inherently rely on accurately capturing the entire spectrum of patient needs. Consequently, instead of transparently acknowledging and addressing the burgeoning demand for specialist services by increasing capacity, some hospitals appear to have adopted a more expedient, albeit ethically dubious approach, simply preventing patients from being added to the waiting lists in the first place. The rejection letters I receive are often bewildering, sometimes even insulting. One common example is a directive to refer to tertiary care, despite the fact that the referral was already directed to a tertiary hospital. Others claim the condition can be adequately managed in the community, even when no appropriate or funded community-based services exist for that condition. I've also seen responses recommending to trial physiotherapy first, despite clear clinical indications for surgical intervention. In some instances, the hospital simply advises that the patient seek care in the private sector, an option clearly out of reach for many. But perhaps the most frustrating is the generic template stating, referral rejected due to inadequate information. This is by far the most common letter patients receive. They return to us confused, anxious, and frustrated, believing something was missed. Yet on our end, the correspondence from the hospital often tells a very different story, such as, we don't have capacity. It creates a disjointed experience where patients are left in the dark and GPs are made to look like the barrier rather than the advocates we are. What makes this more concerning is that hospitals, despite being state-funded, are permitted to create their own internal criteria for accepting or rejecting referrals. Legally, they can reject referrals outright due to lack of capacity, without ever triaging the patient or placing them on a category-specific waitlist. In doing so, the hospital's visible waitlist remains artificially short, giving the illusion of efficiency, when in fact, many people are simply excluded from the queue altogether. And here's the dilemma. If you live in a certain catchment, you're assigned to one public health service. If that single public hospital rejects your referral, there is often no recourse. Patients cannot easily be referred to another hospital outside their area, and many cannot afford private alternatives. They are effectively trapped in a publicly funded system with the door closed. Instead of categorizing the need and managing the wait, rejection is being used as a gatekeeping tool, not to prioritize care, but to reduce the number of people officially awaiting service. That's not triage. That's rationing through omission. The decision-making process appears arbitrary and alarmingly inconsistent across different institutions and even within the same hospital. But the most distressing aspect is that the patient often receives this disheartening news before I, as their referring GP, am even notified. This leaves me in the unenviable position of having to explain a decision I had no part in and often don't understand myself.
Dr. Hope, it's crucial to maintain a balanced perspective. Do general practitioners bear any responsibility in this situation? Are there instances where referrals might be lacking in necessary detail or clinical justification?
That's a valid and important point, John. As general practitioners, we absolutely have a professional obligation to ensure that our referrals are comprehensive, clinically sound, and clearly articulate the patient's needs. This includes providing a detailed medical history, relevant examination findings, results of pertinent investigations, and a specific question or request for the specialist. The most effective referrals are those that are precise, focused, and provide the specialist with all the necessary information to make an informed decision. Furthermore, we also carry a responsibility to adequately prepare our patients for the realities of the public hospital system. We must be transparent about the significant pressures these institutions are under and explain that even if their referral is accepted, considerable waiting times for appointments or procedures are unfortunately common. It's vital to emphasize that these delays are not a reflection of the perceived lack of importance of their condition, but rather a consequence of a demand that far outstrips the available resources. However, let me be unequivocally clear. Even meticulously crafted referrals containing all the relevant clinical information and adhering to best practice guidelines are being rejected. This isn't simply a matter of improving GP documentation. This is a fundamental structural issue within the public hospital system that is causing tangible harm to real people.
Dr. Hope, could you share a specific case that has particularly resonated with you and highlights the human cost of this referral crisis?
Certainly, John. One case that remains etched in my memory involves a young woman in her early 30s who presented with debilitatingly severe uterine fibroids. She was experiencing chronic heavy bleeding, persistent fatigue that severely impacted her ability to work, and a significant strain on her personal relationships and self-confidence. After exhausting all appropriate primary care management options, it became evident that surgical intervention was the necessary course of action. I submitted a detailed referral to the gynecology department. It was rejected. I meticulously reviewed and rewrote the referral, ensuring all clinical criteria were clearly documented. It was rejected again. I even escalated the case through the appropriate channels, advocating strongly for her need. The referral was rejected a third time. Tragically, over the ensuing 2 years of navigating this bureaucratic maze, her condition continued to deteriorate. She unexpectedly became pregnant, a pregnancy that was ultimately complicated by the untreated fibroid. She suffered a devastating miscarriage. Ironically, she eventually ended up in hospital anyway, requiring treatment for a severe infection, experiencing intense pain, and suffering emotional trauma, all of which could have likely been avoided with timely specialist intervention. And the sentence she uttered to me, John, the one that continues to haunt me, was this: I thought I was doing everything right. I sought help when I needed it, but no one helped me. That encapsulates the profound sense of abandonment and systemic failure that these rejected referrals represent.
That's an utterly heartbreaking account, Dr. Hope, and sadly, it echoes the experiences we hear far too often. You're not urgent enough. It's not severe enough yet. It seems like patients are being forced to reach a crisis point before they can access the care they need.
Exactly, John. It's a de facto wait to deteriorate model of healthcare. You're deemed not unwell enough to qualify for specialist attention until your condition escalates to a point of genuine emergency. And by that stage, patients are often suffering unnecessarily, both physically and mentally. This concerning trend is not isolated to gynecology. We're seeing it across various specialties, including hernia repair, orthopedics, ENT, and even mental health referrals. And the inherent inequity of the system is stark. For patients who lack private health insurance or the financial means to pay for out-of-pocket specialist consultations, a rejected public referral can effectively become a life sentence of enduring pain and suffering. I recall another patient, a hardworking tradesman, who presented with a painful inguinal hernia. While it wasn't strangulated and therefore didn't meet the criteria for an emergency presentation, it significantly impacted his ability to perform his job, restricted his movement, and caused him considerable daily discomfort. We submitted a comprehensive referral. It was rejected. So, what is the logical next step in this scenario? Does this individual simply have to endure increasing pain and functional limitations until his hernia strangulates, necessitating an emergency surgical intervention? That's not proactive or preventative healthcare. That's reactive crisis management dressed up as policy. It's a profound failure of our responsibility to provide timely and appropriate care.
And amidst this systemic dysfunction, the general practitioner often finds themselves inadvertently cast as the scapegoat.
Regrettably, that is too often the case, John. Patients are sometimes informed by the hospital that their referral was rejected because your GP didn't mark it as urgent enough, or your GP failed to include sufficient detail. While it's true that, as human beings, GPs are not infallible and occasional oversights can occur, these instances are often the exception rather than the rule. More frequently, the referral is clinically sound and contains all the necessary information. Instead of a simple phone call or email requesting clarification or additional details, the referral is summarily rejected with a generic impersonal letter. The patient understandably feels let down, believing that their GP has somehow failed them. This erodes the crucial trust between patients and their primary care physicians. It fosters a culture of blame and defensiveness, rather than promoting collaboration and open communication between primary and secondary care providers. Some of the most effective and patient-centered specialists I work with will proactively contact me directly or provide specific feedback if any aspect of a referral requires further clarification. That is the model of collaborative care that should be the norm, but unfortunately, it's becoming increasingly less prevalent in a system that appears to prioritize rejection over responsibility.
Dr. Hope, what fundamental changes are needed to address this crisis? What would a fairer and more equitable referral system look like?
The cornerstones of a fair system must be transparency, accountability, and, crucially, political courage to acknowledge and address these systemic failings. Firstly, public hospitals should be mandated to publicly report comprehensive data on the number of referrals they reject and, more importantly, the specific reasons for each rejection. This level of transparency would allow for proper scrutiny and identification of problematic trends. Secondly, there needs to be robust state-level oversight of outpatient departments, extending beyond simply monitoring emergency department waiting times. We need clear performance indicators and accountability mechanisms for referral management. Furthermore, establishing direct lines of communication between general practitioners and hospital triage staff is essential. A simple phone call or email to clarify a query is far more efficient and patient-centered than an outright rejection. And finally, patients whose referrals are rejected must have a clear right to know the specific reasons for the rejection and be provided with information about alternative pathways or avenues for seeking the care they need. Beyond these practical measures, we need a fundamental cultural shift within the healthcare system. The current environment, whether intentional or not, appears to incentivize rejection as a means of managing demand. This is not only unsustainable, but fundamentally unethical. And to be absolutely clear, John, my criticism is not directed at the dedicated and often overwhelmed hospital clinicians. The vast majority of specialists and hospital staff are working under immense pressure and are doing their utmost to provide quality care within a severely constrained system. This is fundamentally an issue of policy, funding priorities, and the systemic environment they are forced to operate within. It's time for policymakers to address these issues from the top down.
Dr. Evan, do you have any final thoughts or advice for our listeners?
If you, as a listener, have experienced the frustration and disappointment of a rejected referral, please know this: it is not your fault. You deserve access to timely and appropriate health care. You did the right thing by seeking medical attention and following the recommended process. And for my colleagues in general practice, I urge you to continue advocating for your patients. Continue to strive for clarity and detail in your referrals. Keep pushing back against unjust rejections, but also be honest and transparent with your patients about the current realities of the public hospital system, even when it's disheartening. And finally, to any policymakers who may be listening, true health equity is not just an aspirational ideal. It requires tangible action. It means ensuring timely access to care, implementing fair and transparent triage processes, and building a healthcare system that doesn't punish individuals for not being sick enough to warrant attention.
Dr. Evan Hope, thank you for your invaluable insights, your unwavering honesty, and your powerful advocacy for patients caught in this distressing situation. To our listeners, if you have personally experienced the frustration of a rejected referral, endured an interminable wait for specialist care, or received a letter that left you with more questions than answers, we urge you to share your story. Your experiences are crucial in illuminating the true extent of this crisis and in galvanizing the necessary changes. It is through open dialogue, collective advocacy, and a refusal to accept silence that we can begin to address what is broken within our healthcare system. Until our next conversation, I'm John, and this has been Heart of Care. Thanks for tuning in to this episode from AMCU Media, where real stories, healthcare, and advocacy come together. We release a new episode on the 28th of every month. We're a small, independent team doing our best to bring you meaningful conversations. And your support means the world to us. Subscribe to our YouTube channel and Facebook page. Just search for AMCU Media. Got a story or topic to share? Email us at amcu@strmedical.com.au. Together, we can do better for care, for community, and for change. Until next time, thank you, and take care.